Hi, I'm Nathan Ritter from CardiaGauge.com. Welcome to the world of ECG interpretation level 3. Ready to complete the picture? Let's get right into it.
The first topic for level 3 is here in the rate section. So this is how you do fast heart rates quickly, which comes up occasionally. So you can count the number of little boxes between each QRS complex to understand what the rate is. So these are the little boxes here. If you count 5 little boxes, so that would be one medium-sized box like this. If you see this, then you've got a rate of 300 beats per minute. If you have 6 little boxes, so that would be one medium box plus one little box. That's what I'm showing here. This is 6 little boxes, then you've got a rate of 250 beats per minute. And then 7 little boxes, 214, 8, 189, and 9, 167 beats per minute. So looking over here in this example, it's about 6 little boxes between QRS complexes, and that means we're looking at a rate of 250 beats per minute on this one. The next topic is under the rhythm section, and we're talking AV dissociation. And that's when the P waves and the QRS complexes occur independently, and then the ventricular rate is faster than the atrial rate. So it's as if the atria are completely separated from the ventricles. And the atria do their thing, and the ventricles do their thing, and they don't talk to each other. So over here I show what's going to happen. The sinus node depolarizes right there. Boom. Then there's a P wave as the atria depolarize. And then there's a focus in the ventricle. It could be in the junction. It could be in the His bundle. It could be in the left ventricle, or it could be in the right ventricle, wherever. There's a focus in the ventricle that goes off, and I show that happening here. And then there's a QRS. And this tracing here shows that there's some P waves happening, but there's not a P wave before each QRS, and the P waves are happening independent of the QRSs. This PR interval is really short. It's a little shorter than this one here, and this one's a little bit longer. And then there are no P waves in these other areas to speak of. So this is an example of AV dissociation. Next up is junctional tachycardia. It's a heart rhythm that originates from the junction, which is the AV node and the His bundle. So in this area here, there'll be a little focus that goes off independent of the sinus node, and then the ventricles will depolarize, and the atria will depolarize in a retrograde direction. So that means you're going to end up having retrograde backwards looking P waves. And the place where you'll generally see that best will be lead 2, because P waves are typically upright in lead 2. So let's look at this complex here. There's an initiation of the beat here, and then there's a narrow complex. So that's one of the hallmarks of junctional tachycardia, is it'll often be narrow complex, but not always, because if there's left or right bundle branch block, then the complex will show that morphology. So it goes through the ventricles, and then it works its way through the AV node backwards, and then the atria depolarize in a retrograde fashion. So you get this upside down P wave here, and you can see those with each of these beats. So junctional tachycardia is regular, it has retrograde P waves, and it's greater than 100 beats per minute. Let's do the level 3 part of AV reentrant tachycardia, and that's over here, the antidromic AV reentrant tachycardia. Antidromic means in the opposite direction of how conduction normally passes. So instead of in the orthodromic situation, when the arrhythmia is using the normal pathway of AV node, His bundle, left and right bundles, and then retrograde conduction through the bypass tract. In this situation, it's the opposite, where the conduction goes forwards through the bypass tract, works its way into the ventricle, and then His bundle, AV node, and then the atria depolarize in a retrograde direction. Here's a schematic of how it looks. The bypass tract leads into the ventricle, and that contracts, and the first part of the ventricular contraction occurs over here. Then the ventricles depolarize. Then there's delay as the conduction passes backwards through the AV node. Then there's a retrograde P wave, and then the atrial conduction wave gets to the bypass tract again, and the whole thing happens all over again. Let's look at an example. Antidromic AV Reentrant tachycardia. So we're looking at something fast and wide with a retrograde P wave, typically right before the QRS. Not always, but typically. Let's look down here. Here, the bypass tract leads into the ventricle, depolarizes. The ventricles depolarize. This is a T wave here, I'm ignoring this. Then there's a PR interval, then a retrograde P wave, bypass tract, QRS, PR interval. So generally, you're seeing P waves right before the QRS. That's Antidromic AVRT. Now we're going to look at ventricular tachycardia versus SVT with aberrancy, supraventricular tachycardia with aberrancy. Basically, we're looking at wide complex tachycardia, and how do you tell the difference between VT and SVT? And it comes up pretty frequently. The first is if the net QRS vector is all negative or all positive in V1 through V6 in all of these leads, then you've got VT. That's called concordance. Then you look for AV dissociation, like we just talked about. If you see that the atria and the ventricles are dissociated, that implies you've got VT. Then, if it's irregular, you're usually dealing with SVT, like atrial fibrillation or multifocal atrial tachycardia or atrial flutter with variable conduction. And lastly, there's the relatively obvious one of the shape of the QRS. If it's the same at baseline as it is with the rhythm strip or the ECG you're looking at, if the morphology is the same when the patient's in sinus rhythm as it is when they're having the arrhythmia, then that tells you that you're dealing with SVT. So for example, if at baseline they have a left bundle branch block, and then they have a fast rhythm with a typical left bundle branch block that looks the same as their previous ECG when they had normal sinus rhythm, you've got SVT. And then if the shortcuts don't work out, there's the long cut, which is using the Brugada Criteria. The Brugada Criteria are an algorithm, basically. So number one, you ask, is there concordance, V1 through V6, like I mentioned above? If there is, then you've got VT. And if you have any of these four criteria, you've got VT. Number two, you ask yourself, is the RS interval greater than 100 milliseconds in any of V1 to V6? So this is a little bit complicated. Let's look at it here. So you're looking at the precordial leads. In this example, we're looking at V4. Here's the start of the R wave right here. And here's the nadir of the S wave here. So we're talking about this time interval. And in this instance, it's about 2.5 little boxes. And that is equal to 100 milliseconds. So this here would be an example of VT by Brugada Criteria. After looking at number two, go to number three. Is there AV dissociation present? If so, VT. And if you've had none of these three things here, then you've got to go on to number four, which is kind of a doozy. And that's the Brugada Morphology Criteria. So if any of the Brugada Morphology Criteria are met, then you're dealing with VT. So with the Brugada Criteria, you got to know several things. You got to know you're looking at leads V1 or V2 for some of the criteria, and then you're looking at V6 for these criteria here. And then you also need to know you're looking for a left bundle type morphology or a right bundle type morphology. And each of those two morphologies have their own criteria. So let's start here. So if you have a left bundle type morphology, that would be if lead 1 looked pretty much like this, V6 looks like this, V1 looks like this. Those would be examples of left bundle type morphology. You're going to apply these criteria here. So first, if the initial R is greater than 40 milliseconds, that implies VT, and that's shown here. So this is the initial R wave, and this would be in V1 or V2. Goes up and down. If this little guy here is more than 40 milliseconds, more than one little box, then you're typically dealing with VT. The next criterion in V1 or V2 is if you have a notched S wave. So this is the S wave here. It goes down, and then there's a little notch in it. Oop. Here's the notch. If you see a notch in the S wave, I like this one because it's relatively easy to remember and apply. If you see a notch in the S wave, you're dealing with VT. And then the last one of these criteria is if the onset of the QRS to the nadir of the Q or S greater than 60 milliseconds. If this were a QS, it would look like this. But it's got, this one here has an R. So the onset of the QRS is here, and then the nadir of the Q or S, in this instance it's an S. Here's the nadir if this time is greater than 60 milliseconds, VT. Well, say you have none of these things up here, and you've got a left bundle branch block morphology, you go on to lead V6. If you see a Q wave, or you see a QS complex, meaning it just goes down and there's no up at all, these would be very atypical for SVT. That means you've got VT. This one's also pretty easy to remember. And then let's go over here to the right bundle morphology. So if you see something that looks more like a right bundle, so for example, it's mostly positive in lead V1, looks like this, or it looks like this in V1, then you're going to use these criteria here. So the first one is here, a monophasic R or QR in lead V1. So let's look at this one. There's just a monophasic R wave. There's no notches. It doesn't look like this. It doesn't look like this. You just got one up and down. Or you've got a QR complex in V1. And then here's my favorite of the Brugada criteria because it's pretty easy for me to remember, and that is the R is taller than the R prime in lead V1. So what that means is you've got the R here and the R prime is here. And basically what we're talking about is the first bunny ear is taller than the second bunny ear. And that's actually really abnormal for right bundle branch block. With right bundle branch block, almost always the first bunny ear is taller than the second one. So I find this one really easy to remember. And then the last one's here. You've got the presence of an RS complex in lead V6 with a right bundle branch pattern in V1. So it goes up, it goes down, RS in V6 when you have a right bundle branch block pattern. And again, if you have any of these criteria, it makes it more likely you're dealing with VT. Let's do an example. So let's look at this tracing here. We've got a fast, wide heart rhythm. I can't really see any P waves. We'll do the shortcuts. First, we'll see if there's net QRS vector all negative or all positive in V1 through V6. And so it's positive in lead V1, positive V2, mostly positive in V3, but then it's more negative in V4, V5, and V6. So we do not have the first of the shortcuts. Then we look for AV dissociation and as I mentioned, we can't see any P waves there, so can't tell. We ask, is it irregular? And it was regular. And then we don't have an old ECG to look at, so we can't say if the morphology is the same as when the patient's having normal rhythm. So we're stuck with the Brugada criteria, and there's no concordance. The RS interval does not appear to be greater than 100 milliseconds in any of V1 or V6, although it's close. Let's look down here. Here's the onset of the R and the nadir of the S, and it's basically close to 100 milliseconds. It might be about 100 milliseconds, but we're not meeting this criterion. Clearly, no AV dissociation, and then here's the morphology criteria. So first, we're going to ask ourselves, do we have a left bundle morphology or a right bundle morphology? And I like to look at V1 for that. So in V1, it goes up mostly, so that's more of a right bundle branch block morphology than a left bundle branch block. So we're over here. So let's look here. Do we have a monophasic R or QR? And the answer is yes, we do. We have a monophasic R wave. Looks a lot like this. So that implies VT. And then let's look at this complex here in V6. And indeed, we've got an R wave and then an S wave in V6, which is what we're looking for to satisfy the Brugada criteria. So by both of these two, it suggests VT. So that's an example of monomorphic sustained ventricular tachycardia. All right, let's do this example of VT. Here we go. First, we've got fast, wide rhythm. Don't really see any P waves that I would know for sure was a P wave. We'll check for concordance, and lo and behold, we have that. As you can see, the QRS complex is net vector positive in all 6 of these precordial leads, the V leads. So that's a nice, relatively clear-cut example.